over TTM and then some neuroprognostication. Kind of just a brief history of TTM. The idea of targeted temperature management actually dates back to Hippocrates, and he noticed that wounded soldiers did better when they were packed in ice, basically. And then French invasion of Russia, so one of the surgeons discovered that as well. Actual use of targeted temperature management, previously therapeutic hypothermia, started around 2002 after a couple of trials came out. And at that time, they recommended cooling out of hospital cardiac arrests that were VFib or VTAC. This whole PEA arrest was kind of an outlier, and we eventually started cooling them as well, but there wasn't really good evidence, still is not good evidence for the cooling of PEA arrest. There's actually not a whole lot of evidence for in-hospital cardiac arrest patients either, and it's not because it's not beneficial, there just haven't been extensive studies on them. So then in 2021, the TTM2 trial came out, and that compared normothermia to hypothermia. And overall, there was not a statistically relevant difference between hypothermia and normothermia. PEA arrests were still not really studied in this. It was mostly VFib and VTAC arrests, and then in-hospital cardiac arrests really weren't in the trial either. So why should we maintain, this is supposed to be participation, so Shelby and Megan, you're going to have to participate. Sorry. Why should we maintain at a minimum normothermia in cardiac arrest patients with impaired neurological function? What is the reason for fever prevention?
Doesn't the fever use up some of the
Megan, you're going to have to type it because I can't hear.
Okay.
Yeah.
Okay. On volume.
Oh, Shanna's going to fix it so that I can hear you.
Didn't realize I had the volume off. Sorry.
Okay, go ahead,
Volume's
Megan.
on.
Can you hear me then?
Yes, I can.
Okay. Isn't it basically a fever is going to be using up some of the resources and God, my brain is fried. Like oxygen demands and everything for your brain and
yeah, so it increases metabolic demand on the brain, which Shelby had typed. Yeah. So think of like your head trauma patients. You don't want them to have fever because it increases metabolic demand on the brain. So same thing with your cardiac arrest patients. What are the complications associated with hypothermia? So if we cool people down to 33 degrees, what are the potential complications? Shivering, yeah. No, you cannot answer, Shanna. So bradycardia is a big one. And the bradycardia associated with hypothermia is not responsive to atropine. So you have to do dopamine, maybe warm them up a little bit more, potentially do a temporary pacemaker. That's a lot of crap to do to somebody just to keep their heart rate up because you cool them. Bleeding because your coagulation system is defective. Hemodynamic instability because it causes vasoconstriction, which can impair your cardiac output. Reduced gut motility, you can't really feed these patients. Electrolyte disturbances due to increased renal secretion, aka cold diuresis. Increased risk of MI due to vasoconstriction, hyperglycemia, lactic acidosis, reduced drug clearance. So those are all associated with hypothermia. So what population, aside from VFib and VTAC arrest, because that's what the TTM2 trial has said, should not get hypothermia? That would be anybody who's hemodynamically unstable. So if you have a person on a high dose of vasopressors, they shouldn't be cooled regardless of their neurological function. bleeding issues, DIC, trauma. Back in the day, they used to say sepsis, but that doesn't really apply so much anymore. So we either cool a specific patient population or we keep them normothermic, and then we can do neuroprognostication. Rule of thumb is minimum of 24 hours, generally give them 72 hours before we do neuroprognostication. And that's regardless of temperature modality. When we cool them, we have to give them the full 72 hours. Criteria for brain death would be the absence of all reflexes. Keep in mind that there are some spinal reflexes that are still intact, even though your brain has died. So as awful as it sounds, compare it to when you were dissecting a frog in school and you touch a nerve and they jump. That can still happen with these patients, even though they're brain dead.
That to declare brain death, they do have to be normothermic.
Yes, at least 36.5 degrees. There is one medication that can mimic brain death. Does anybody know what that is?
Like baclofen.
Yep, baclofen. So you have to give that 7 half-life eliminations, which ends up being like a day and a half, I think. It might be 2 days before you can do any sort of neuroprognostication on a baclofen overdose, because they're going to look like they're brain dead. So I'm going to go over some cases just to kind of discuss who would get what kind of treatment. So we'll start with a 65-year-old female with a history of COPD on chronic oxygen at 3 liters per minute, has been struggling to breathe for the last couple of days. She went to her primary care provider and was started on prednisone and a Z-Pack the day before. Today, her daughter got up to make some coffee, was out of the room for about 8 minutes, and came back to find her mother unresponsive and not breathing. Checked for a pulse and there was none. She started CPR. EMS arrived and found the patient to be in PEA and continued CPR en route to ER. CPR continued in ER. ROSC was achieved after 5 minutes in the ER. Total downtime was roughly 28 minutes. Was PEA the entire time. Neurological exam post-ROSC. The patient withdraws from painful stimuli, but there are no spontaneous movements and the pupils are sluggish. Kind of intervention, if any, would we be doing for this patient? So this patient actually would be somebody that we would look at for actual hypothermia. The reason being it's PEA arrest, and while there's not clear-cut evidence to support it, hypothermia does still have a place for PEA arrest patients, especially with the prolonged downtime and the neurological function that she has. This is going to be provider discretion. At a minimum, she has to be normothermic. A Zoll catheter should be placed, and she needs to be at least 37 degrees, 37.5. But she would be a candidate for hypothermia. Right, so we have a 43-year-old male with a history of CAD, comes to the hospital with chest pain. EKG shows an anterior STEMI. Cath lab is called. Patient suffers a VFib arrest before cath lab gets to the hospital. ROSC is achieved after 2 rounds of CPR. Patient is minimally responsive, will open eyes to deep sternal rub, withdraws from pain. He is taken to the cath lab and receives a stent to the LAD. What would we do for this patient?
You wouldn't want to cool him, would you? Because if he's going to calf, he's probably getting like blood thinners and stuff.
So you're correct, and it's not because of the cath lab. The TTM2 trial said that those in VFib or VTAC, they just didn't find any difference in outcomes, and there's too much risk associated with cooling, so there's not a point of doing it.
Kelly asked, does downtime matter?
In VFib, VTAC arrests, no. I mean, you can still consider cooling, but there's really no indication for it based on the recent guidelines.
External rub, does that
No, and the patient needs to be alert, oriented, able to follow, not necessarily oriented, but alert and able to follow commands to not qualify for any sort of targeted temperature management. So he would just get normothermia, and hopefully cath lab, the physician is nice enough to put in a Zol down there. All right, we have a 76-year-old male presented to the hospital 4 days ago with pneumonia and was admitted to 3 North. He had been improving, however, overnight he started to require more and more oxygen. He was also tachycardic and hypotensive, complaining of chest pain. The nurse was in the room with the patient when he went unresponsive, went into cardiac arrest. She immediately started CPR. LifePack showed patient to be in PEA, continued CPR per ACLS guidelines. ROSC was achieved after 33 minutes. EKG shows mild ST depression in the anterior leads. So the first question here is, what do you think the differential diagnosis is? So where I was going with this is a massive PE resulting in cardiac arrest. So what would our treatment for that be? TPA.
Honest answer.
You can. Yes. TPA for a cardiac arrest, you give 50 milligrams IV push. And if you don't get ROSC within 15 minutes, you give another 50 milligrams IV push. If you do happen to get ROSC within 15 minutes, you give the additional 50 milligrams over 2 hours. So regardless, they're going to get 100 milligrams of TPA. Obviously, if we're giving TPA, we do not want to cool the patient because we're going to make the bleeding worse. So he would be normothermic. With TPA administration, you can do heparin immediately afterward, as long as the PTT has fallen down within a therapeutic range for our heparin order set. So that's just without a loading dose. You don't have to wait a certain amount of hours or whatever. It's you check the PTT every 2 hours until it's within that therapeutic range, and then you can start heparin.
Try to get like all your invasive stuff intubating.
You would like to. Ideally, yes, but it's not a requirement. I put lines in post TPA patients.
That was my next question, because there's a lot of, it's still gonna always get provider discretion, right? Like, it's the suggestion to not do it, but it is always a provider discretion on whether or not you do it. And on this patient, would you still go ahead and place a Zol catheter for normothermia?
Yeah, because neurological exam post ROSC, he's unresponsive to painful stimuli. Pupils are still responsive. No, it's fine. So he needs to be maintained normothermic. I would still put a Zol in. It would be femoral. I'm not going to go poking in the neck. And I've put arterial lines in post TPA patients too. It is doable. And her bleeding out actually came because we crushed her ribs and she bled from there, not because of the line placement. So, next patient. 35-year-old female with intentional overdose is found unresponsive in her home by her boyfriend. Unknown when she overdosed. Just found pill bottles, which consisted of metoprolol, lorazepam, fluoxetine, and oxycodone. And he also found a note. He found her to be pulseless and started CPR. EMS arrived and found the patient to be in PEA. Got to the ER with CPR in progress, continued CPR for 15 more minutes, and ROSC was achieved. Total downtime is really unknown because we have no idea how long she was down before her boyfriend found her. CPR occurred for 45 minutes. Patient is unresponsive to painful stimuli. Pupils are fixed and dilated. She is having myoclonic jerks. Patient is requiring high-dose vasopressor therapy, which does improve somewhat after lipid emulsion. However, she remains on vasopressin 0.04 units, norepinephrine 20 micrograms, and epinephrine 3 micrograms. She has a fibrinogen of 65, INR of 2.6, platelets 75,000. She is having some bleeding from the nose as well as NG2. So I want, first of all, what are we going to do with this patient?
in what regards?
in terms of temperature management. So normothermia because she's hemodynamically unstable and she's in DIC. If those are there, then she would also be a candidate for hypothermia. So the other thing we need to look at too, and you cannot say she's brain dead the moment she comes in, but myoclonic jerking doesn't necessarily mean that there's brainstem activity. So you need to look, is she breathing over the vent at all? Does she have any sort of reflexes intact? That includes, for those of you who know how to do it, break out the reflex hammer and see if anything happens. That's going to tell you off the bat what the prognosis is. The fact that she's got fixed and dilated pupils and she's after an opioid overdose and she's got myoclonic jerking, her prognosis is very poor, especially with the long downtime. Okay, I have two more and then I'll go over neuroprognostication. So we have a 69-year-old female in the hospital with CHF exacerbation. She is due to have a stress test later in the day. However, she develops acute chest pain. EKG shows inferior MI. She is normotensive with a blood pressure of 110/60, continues to complain of severe chest pain, and is given nitroglycerin. Inferior MI, nitroglycerin. What's the problem there? So this is the right side of the heart, Shelby. These people are preload dependent. You vasodilate them, you're going to bottom out their blood pressure. These are the patients who are potentially in a cardiogenic shock state. And they actually would benefit from fluids. Obviously, you don't want to go and, oh, she said slow type. Obviously, you don't want to go and just pump tons of fluids in them, but they need preload. She had been diuresed for the last 3 days, and her BUN has already started to elevate. So she was dry before we gave the nitro. After nitro, her blood pressure drops to 62/41. Fluids are started, however, she continues to decline and goes into an arrest. Rhythm actually turns out to be VFib because the patient was in the process of having an MI. She undergoes CPR, receives multiple shocks, and epinephrine and lidocaine. ROSC is achieved after 22 minutes. She is taken emergently to the cath lab. Neurological exam reveals a GCS of 5. She did not receive any procedural sedation. So would we maintain normothermia or hypothermia? So for this patient, normothermia, sorry.
General, your VTAC patient, and we know what was wrong with her, obviously.
Yeah.
And long, like to get her fixed, so you're still just gonna do more. And there's still no indication for either.
Yep.
It's hard to wrap my head around. We've done hypothermia for so long.
There's just a very specific patient population for hypothermia. All right. 40-year-old male with acute heart failure secondary to Takotsubo cardiomyopathy had been admitted to CVU. EF is 20%. He starts complaining of shortness of breath and rapidly decompensates due to flash pulmonary edema. He is found profoundly hypoxic, even on BiPAP with an FiO2 of 100%. And we'll say that his EPAP is 10. He is saturating 85% and breathing 40 times a minute. While prepping to emergently intubate, the patient arrests. He is PEA. ROSC was achieved in 10 minutes. Shortly thereafter, the patient is awake and responsive, able to follow commands. What are we going to do with this patient for temperature management?
Just going to monitor normothermia.
You just have to monitor. We don't have to do anything. He has no neurological deficits. He's able to follow commands. He's awake. I mean, obviously treat fevers, but you don't have to do it with a Zoll catheter unless for some reason he gets some absolutely uncontrolled fever. That's not anything I wouldn't do in like a septic patient with serotonin syndrome whose temperature is out of control. It's not because of neuro issues, it's because the temperature being that high is bad for them. Like our lady that we have in ICU right now, she was actually a PEARS, but only did CPR for like 5 minutes. And she was awake following commands, doing fine. She has no indication for any targeted temperature management.
And that way, I'm gonna do even more on
The AHA actually released a statement last winter that supports normothermia. So that's in their guidelines even now. That they're not giving clear-cut guidelines on cool, not cool, but absolutely fever prevention in those with impaired neurological function. So we'll go back to the overdose patient. We didn't cool her because of all of the instability. 48 hours later, she still got fixed and dilated pupils. She's no longer having myoclonic jerking, although between hours 12 to 24, she was in status despite multiple different seizure medications until we finally gave the push dose phenobarbital and stopped feeding. She's not breathing over the ventilator. She has no brainstem reflexes. So now we move on to neuroprognostication. Neurologists should be involved with this. And they'll come in and confirm that she has no brainstem reflexes. So he's going to see if there's any response to verbal stimulation, painful stimulation, and he will check at all of the extremities, as well as the face, the neck, various locations that they check. If he doesn't have any response there, he'll check reflexes, including the cold chlorics, and patients who have brainstem activity, their eyes will move. I think with the cold, it's away from the cold. If it's warm, it's towards the warmth. If they have no brainstem activity, their eyes will not move. It's the same with the doll's eyes. The whole point is if you are brain dead, move your head to the left, but your eyes stay where they were, basically. After all of that, the number one test to say yes or no to brain death is the apnea test. So the patient's hyperoxygenated for 10 minutes or more. And then they also have to have a normal pH, and preferably a normal PCO2. Obviously would need to take into consideration those chronic COPD patients who live with a CO2 of 60, because you want their pH to be normal. If you try to normalize their CO2, they're going to be alkalotic, and it's not going to work. Once you have them within that normal pH range, you're taken off the ventilator and a suction catheter is put down the ET tube with some oxygen going through it, and you give them about 8 to 10 minutes. Them back up to the ventilator after you have drawn an ABG. The ABG should show a change in carbon dioxide and respiratory acidosis. They're also observed during that entire time to make sure that they have no respiratory movements. If they have any respiratory movement, you stop the test because obviously they're not brain dead. If they become hypoxic or hemodynamically unstable, you have to stop. You have to stop for the latter two reasons. That's an inconclusive test. And then you moved on to the cerebral perfusion scan, which is done. They do stress nuke med. There we go. So things that need to be absent before neuroprognostication, they cannot be hypothermic, they cannot be on paralytics. So train of 4 is important here because yes, they will actually still have a train of 4. No sedation, no analgesia. They cannot be hypoxic or hypercapnic. No hypotension, no hypoglycemia. Make sure that all of their endocrine stuff is taken care of. So no mixed edema coma with a TSH through the roof. Spine injury is kind of complicated. Oh, here it is. Baclofen. Half-life elimination is 2.8 to 4.7 hours, so we'll say 5. You need to have 7 half-life administrations, so whatever 5 times 7 is, what, 35? Has to be a minimum of 35 hours before you can neuroprognosticate somebody with a baclofen overdose. Other medications for patients to consider: fentanyl, oxycodone, Precedex, diazepam, lorazepam, midazolam, phenobarbital, pentobarbital, propofol, Ambien, and Vivitrol. Any questions on neuroprognostication?
At what point do you in your practice make sure that neuro is involved?
They technically should be on any cardiac arrest patient with impaired neurological functioning.
So from the get.
Yep. And a lot of these patients should get continuous EEG monitoring off the bat. Like, yes, we can put Cerebell on, but Cerebell doesn't detect seizures in every area of the brain. So it's nice for quick check, but they really need continuous EEG.
So with that, with the Cerebell, like I'm thinking of a patient we had the other day that was like an overdose patient. We threw Cerebell on immediately to look for, if it picks up potential seizures. Do you go ahead and treat at that point to try to prevent and then
Yep.
get neuro involved? Okay, so good for like quick. We have a cardiac arrest patient. Obviously, neuro's not on yet, or we can't get EEG in there right away. So still place Cerebell, then wait until we can get EEG, but EEG is definitive.
Yeah. The only time I would say don't put the Cerebell on is if it's going to be a very short window between EEG coming.
Okay.
Like, please don't charge them for that band.
But really, other than like, charging somebody,
There's no reason to not.
Yes.
And non-convulsive seizures should still be treated just like a regular seizure. So do you guys have any questions regarding hypothermia, normothermia?
Okay. Like from a GI standpoint, should we be starting with all these patients?
Minimum a Zoll needs to be put in. So the question was, from an ER standpoint, should they be starting to cool the patients? Or not necessarily, because we don't know that we're going to cool everybody. The window still stands at 6 hours, although obviously we can cool much faster because we have the Zolls. This kind of is outdated with the use of Arctic Sun, because that took forever and a day. But window is still 6 hours post ROSC. So I've requested that ER get in the habit of placing Zoll catheters if they're already going to put in a central line. I know it is going to be a forever battle. I will eventually win this.
Considering the point where I can educate, like, and it's not the clear when they're training educate. Why don't we do already teacher and anyway? And he was talking about the moment at the end, just talking about stuff, but really we don't, like, we do it upload.
And this is, so I sent him a case recently.
Yeah.
We had a patient who arrested in the ER, prior to coming to ER, got ROSC in the ER, sat down there for however long. By the time he got to ICU, his temperature was 102, which is absolutely not acceptable. And I've had this discussion regarding Zoll catheters and was told that they're more complicated. So my smartass said, well, I'm a lowly NP and I can put them in. So it was not received well. But
In most of these cases, we're going to place it because we want to at least put them on the thermic, so that they don't get to that point. So Taylor, can you just explain for the group and those online and those on the recording what that high temperature? I mean, most of us know, but just to reiterate, what that does to the patient's brain and their neuroprognostication if we get a fever whatsoever after we've had.
Kind of worse than the injury that's already there. You're putting more stress on the brain that it does not need. That's the same with hypoxia. So these patients should never be hypoxic. Obviously, there's some instances we can't avoid. Let's say it's a trauma patient. We're obviously not going to cool them, but we should maintain normal thermia. But if they have severe pulmonary contusions, there may be nothing we can do to prevent hypoxia, with the exception of starting these patients on ECMO, which we would then ship out. But they should have an oxygen saturation just like your stroke patients, maybe not 95, but at least 92%. So anything to reduce demand on the brain.
Yeah, I mean, from a nursing standpoint, like staying up, like down, I think would live up here. So we at least start with the ice packs.
You can, yeah.
But I think it was.
Anything to try to keep them from getting a fever. Like right now, it is what it is. They're not going to put the catheters in.
I think what you can do from a nursing standpoint and from an educator standpoint is educate on getting temperatures in general. I mean,
Everyone should have a continuous temp probe.
start there. So right there is you've intubated this patient or cardiac arrest. You've intubated the patient. You're going to place a Foley. Place a temp sensing Foley always, no matter what, and then go ahead and get it hooked up if you can, so that you can take continuous temps. And if for whatever reason you can't, or it's going to take a while, get temps every 15 minutes. Yeah. That way, if you start to see that fever, that is MO for you to say, doc, our temp has gone up, even if it's only 0.2 degrees for every, every like point. I think it's for every degree Celsius that like metabolic demand increases by like 8% or something. I don't know if I'm saying that exactly right, but think about that metabolic demand on the patient's brain for every little bit past normal thermia. So that is then your opportunity to say this patient is in the beginnings of a fever. We need to keep the normal thermic at the very least. Would you consider placing a Zolt? Or having that nurse, the patient's going to ICU, right? They probably already have a bed potentially, or potentially have a nurse, or at least know they can text the charge nurse and say, this patient is starting to, it is starting to get a fever. I've got them hooked up to their Foley tip probe. They're starting to get a fever. I would suggest, I can't get whatever Dr. So-and-so to place the Zolt. I have suggested it, but that way they know when they come up, then that person's going to have it all ready to go, and that intensivist is going to place it immediately.
And another thing from the ER perspective, I don't know what the ER to provider to nurse relationship is like, but if you guys can just say, hey, what do you think about a Zolt? And just keep hammering that in. Maybe they'll get sick and tired of hearing you guys and me, and they'll start doing it. Another important thing that I want to touch on, if they come in hypothermic, like 32 or more, leave them there. Do not warm them up. Now, obviously, if they're below 32 degrees, then that's going to cause all kinds of problems in terms of instability. But if they are stable at 32, 33 degrees, leave them alone. Put that Zoll in, keep them there.
Like, are pretty good about leaving in those, like, pretty regularly. But by the time we get them, like, they're freshly cut rocks. And so they're not getting through the A or an alpha. So, like, that's when they're really not always good.
No. That would be better. Because if they're not making urine, no, it's not accurate. The other thing with the Foley catheter ones is 9 times out of 10, we're sending them to MRI at some point. So we have to take it out and put in a different one. So I would say for you guys, do rectal or esophageal, and then we can deal with the Foley one if we need to. But I mean, they're going to have a catheter in, but if we decide we need to put in a Foley one, we can switch it out.
But then again, that's another piece of when I'm making a urine output, I can't get a temperature. I'm doing an oral temperature, and this is what I'm getting, and I don't have a way to continuously monitor again. Like that's probably this patient is sick, and we need to keep them normal temperature. Rachel was just saying that she talked to the rep from BARD on tips and Foley. What they are stating is that you do not have to have the 30 mils per hour of urine output. So we'll get some more information on that. And that we and that's maybe that is the device, specific to this Foley. But with more information on that. I mean, if that's the case, then right there, no problem. But
yeah, she actually sent me a study with it, that I can send out to people if they want to. I haven't had a chance to read the whole thing, but the conclusion said all those statistically significant, the mean change gradient between the intervention and the control groups was not clinically important, indicating the water temperature remains reliable even with significant changes in urine flow.
Now, I would assume this doesn't qualify if they're anuric, but oliguric, sure.
that's something to think about for future.
And then for ICU and CVU, remind your providers to put Zols in these patients, because we have a habit of just throwing in a central line and you're like, oh, we probably need a Zol too. And then we put 2 potentially infectious sources in the patient. So the Zol has a central line. It would be best to just do 1 line.
Okay, sorry, we that they can hear me on there. Would you say that the general consensus of our intensivist group is now that we will place the Zol and keep the patient normothermic if you, or at least have it in place for any fever prevention? Like we're not.
Yeah, they don't have to
preemptively decrease fever and not wait till we get a fever to place it.
Yeah, they don't have to be automatically hooked up to the Zol machine. As long as the catheter is there, it can stay in for several days. And then if their temperature creeps up, we can immediately intervene. So they hit 99 degrees. We start Zol instead of, oh, now I have to put a catheter. I literally sat there putting in a Zol and watched somebody go from 100 to 103 in the time it took me to put that catheter in.
And the Zol machine itself only takes, we could get a patient from normal thermia down to 32 degrees within an hour. So we just need to drop them 1 degree. I mean, we're talking 15 minutes.
And please make sure the little thing is spinning. I had somebody we were trying to warm up because he was 88 degrees Fahrenheit and it wasn't spinning, and they kept telling me it was working fine. I'm like, no, it wasn't. So then I FaceTimed Shanna.
So, and then just know those catheters, if you use the Solex into the net, that is good for 7 days. It's called Solex 7. It's good for 7 days. The Quattro in the femoral. The Quattro is good for 4 days. So we can use them. And correct me if I'm wrong, then if we're done and we don't need any, normal thermia or cooling or warming measures, and we need it, and it's time to take it out, can you guide wire in then a central line if we have to take out that device? Or
you can, but I'd rather a PIC just get placed because there's infection risk with catheter exchange. Important information about the Zol catheters. If you have an obese patient, they should be getting the femoral. It works better to cool.
What?
So.
Covers more.
Yep. Any other questions, comments? Okay, well, that's all I have.
Thank you guys for coming. Thank you for being online. I'll go ahead and stop recording.